So in today's session, I wanted to just touch on lid malpositions. I think it's always easiest to split things up into small little chunks rather than go through a massive amount. So we're going to talk mainly on so today's session is basically mainly looking at entropions and ectropions, ptosis, and I'm going to just touch on lid retraction at the end. Um, I'm only going to talk on these topics, A, because just timing wise, I don't take too much of your time, and B, um, I also wanted to spend some time talking about the actual operation, because I think sometimes people always, at least when I was learning, unless you're actually on a plastics firm, it can be a bit difficult to understand how the operations work and what they're doing. So I'm not going to talk about all of them. I'm just going to talk about the main ones that you would do for the main causes of entropions, ectropions, which is actually a very similar operation, and then uh, talking about ptosis as well. So if we start off, entropion basically just is what it says. So it's some inward turning of the lid. Now, there's lots of causes for this. Typically, it's involutional. So um, the what happens is over time you have lid laxity, um, and that then essentially means that the lid isn't sitting tightly against the globe, and then that can cause either an outward turning or an inward turning. That's the sort of typical cause. It can also be cicatricial. So what that means is that you get tightening of the posterior lamella, and we're going to go into the details there. And actually, entropion can sometimes be much more intolerable than ectropion. So reason being is with ectropions, usually the patients have watery eye. Sometimes they're able to deal with it. But with entropions, especially patients with good going lashes, they're going to get a lot of discomfort on the ocular surface. These lashes can um, rub away at the cornea, causing ulcers, infections, and it can cause a lot of havoc actually. So the patients can be really quite uncomfortable. So involutional entropion, you sort of can think about it in the three different things are working together against the patient. So your inferior retractors, which usually pull the eyelid away from the eye, they get weak or they dehisce. You then also have some horizontal lid laxity, and then your orbicularis also then starts to override. So these three things together um, are sort of the triad of things that are going on, mechanically speaking, to actually cause an entropion. And if you think about what we're essentially doing when it comes to operating or how to actually treat entropion, we're looking at these three things. So typically, from an operative point of view, what you're going to do is deal with the horizontal lid laxity, and then you're also going to deal with the inferior retractor weakness. But what you can sometimes do is just with a bit of Botox, you can actually sometimes fix entropion by just relaxing the orbicularis, and then that also pulls the eyelid down. You want to look at your lid movement. You want to understand whether or not there's which way is the laxity coming in from? Is there a huge amount of medial canthal laxity versus lateral canthus? And you also want to just check that the anterior surface is okay. Because if you have a patient whose anterior surface isn't really that bothered and the patient's not that bothered, then obviously you're not going to necessarily operate and you might be able to just get away with some lubricants. But if you're having a lot of anterior surface discomfort, a lot of kind of abrasions on the cornea, then you might want to try and tell the patient that actually doing something about this is probably best. And the treatment is essentially you're going to shorten the lid horizontally, and you're also going to do some everting sutures. And I'm going to talk about the operations a bit later. So I wanted to touch on ectropion first, and then because the operation is very similar, I'll talk about that afterwards. With cicatricial entropion, the cause is a bit different. What's actually happening is your eyelid is being pulled towards the eye, and that's usually because you've got some posterior lamellar shortening. Now, that can be secondary to all sorts of things. Most commonly, especially in the upper lid, it's trachoma. Previous trachoma causing a cicatricial conjunctivitis, and that then scars and shortens the posterior lamella, pulling that eyelid towards the globe. Previous trauma, penetrating trauma to the lid, if they've had some scarring as a result, that can pull the eyelid in. And also inflammatory diseases, so things like ocular pemphigoid, Um, these can also then, over time, cause cicatrizing disease of the posterior lamella and pull that eyelid in. Now, the management of cicatricial entropion is a bit different. Surgery isn't necessarily the mainstay of management. A lot of the time with these patients, what you're actually trying to do is just avoid or control the cicatrizing process as much as possible. So, with infections, treat the infection. With inflammatory things, you're going to, think about using some steroids. Um, Lots of lubricants, and the surgical management depends on the extent of the cicatrization and where it is. So a lot of the time you could think about just opening things up, putting in some amniotic membranes, or even mucosal grafts, so things from neighboring conjunctiva, or even potentially like things from your buccal mucosa, for example, inside your mouth. These are all things where we can try and graft mucosa to lengthen posterior lamellas or lamellae rather, and move the eyelid off the globe. So cicatrizing entropion it's definitely worth checking that that's not what's going on. So you're going to pull that eyelid down. You're going to see whether or not there's a lot of phonoceal shortening. You're going to see whether or not there's any symblepharon that you can see, or any evidence or history from the patient. Have they had previous SJS? Have they, had previous trachoma? Do they know about that? Have they had trauma to the eye? And these are all things that can lead you to kind of understand what you're looking at, because for these patients, your typical LTS and everting sutures is not going to work. And the last thing you want to do is start in theatre and actually it turns out they're cicatricial and you have to change your plans entirely. So do make sure you are completely assessing the fornices for these patients and check that you're not missing anything. Ectropion is essentially the opposite. So again, it's typically involutional. You can have some cicatricial or paralytic processes, and we'll talk about those. So your involutional entropion is really the most common thing you're going to see. So it's essentially, again, tissue laxity, but that instead pulls away from the eye. Now, how you're going to assess for that is you're going to look at the lid laxity, you pull it away from the eye and check your snapback in your own eye. If you look into the mirror, if you're pulling your eyelid away from your eye, that should snap back to the eye really quite easily. Whereas with patients with lid laxity, you might find there's a bit of a delay before that lid sits up against the eye, or they actually need to squeeze their eye shut before it actually comes back, or they need to blink a few times. Now, that tells you that they're very, very lax. The other thing that you want to look at is also both the lateral and medial canthal tendon laxity. Now, the reason looking at both is important is because, again, it makes your management a bit different. So, with lateral canthal tendon laxity, you're essentially just moving, as it shows in this picture, the eyelid back and forth. But with medial canthal tendon laxity, the medial canthal tendon is essentially what pulls your eyelid towards that medial canthus. And the way you can check whether or not there is a lot of laxity is by pulling that eyelid out and you're looking at the lower punctum. So your lower punctum, if you're pulling your eyelid, if you look in the mirror, it shouldn't really move by very much. Whereas in these patients with MCT laxity, their lower punctum can go all the way up to the limbus. And if it crosses the limbus, then you know you've got a lot of tendon laxity. And actually, what that tells you is that your medial canthal tendon is actually something that also needs tying down rather than just your LTS. Um, and again, like I said, so with involutional entropion, again, it's the same thing. So you're usually just managing it with lid shortening. Cicatricial ectropion, again, these are patients that are usually due to anterior lamellar shortening. So again, ocular rosacea, for example, patients with eczema underneath the eyes, patients who've again had previous surgery, trauma to the eye, and all that scarring has essentially pulled that eyelid down. And the way you can sort of tell whether or not there's a cicatricial process is by actually seeing whether or not there's any movement of the cheek when you're pulling these eyelids up, as in just on the side of the eye, when you're pulling the eye up, is there any movement of the upper lip? Is there any movement of the cheek? And that tells you whether or not there's actually any forces that are pulling that eyelid down from the anterior lamella rather than just involutional processes. And these are usually patients that you're going to treat with skin gaining procedures. So things like a Z-plasty, which tries to open up the scarring. You may actually try to remove some of your scar tissue. All these are patients that may benefit from a flap or a graft if they've actually lost quite a lot of skin, and actually need quite a lot of that skin replaced. Your mechanical ectropion, you're not going to see this very often, but it's a basically just mass effect. It's not particularly complicated. They're just a massive thing on the eyelid and it's pulling it down. And you're essentially going to just remove the mass. Now, over time, with that eyelid being pulled downwards, it can develop laxity. So after the mass is removed, you may actually also need to do some horizontal lid shortening procedures. Um, and depending on what the mass is. You're also then going to consider doing, is this a Mohs? Do you need to remove a lot of the lid? Are we doing reconstructive surgery, etc.? But this is not something that you will commonly see. And lastly, just to comment on paralytic ectropion, these are usually secondary to a Bell's palsy, and you can tell that because there's a weakness of the entire side of the face. You'll usually give these patients some time before you decide to operate on anything. But if they're left with this ectropion, then again, horizontal lid shortening is usually um, something that you can consider doing. So, talking about horizontal lid shortening, your most common thing that you're going to see is a lateral tarsal strip, where you release uh, the lateral canthus and then take a bit off and tie it back down tighter. That's what you're going to see most commonly. A wedge excision is where you actually remove a wedge of your eyelid, and that's usually left for those who have very, very bad laxity or patients who need an entire wedge excision or even for those with masses. Kuntzman is essentially a wedge excision plus removal of excess skin. So these are patients who have dermatochalasis of the lower lid. And a medial canthal resection is very similar to a lateral tarsal strip, but you're doing that on the inside of the eye rather than on the outside. And that testing that laxity is really important because then you know whether or not you need to do that. Because if the medial canthal tendon is the problem and not the lateral canthal tendon, then treating and doing an LTS is not really going to fix the problem, and may actually, in fact, make the problem worse because then you'll pull that lower punctum, you can make the eye very watery, and you're going to kind of mess with their lacrimal system. So just check that you're not missing any medial laxity. So a lateral tarsal strip, I'll just talk about this as best I can with some pictures without you actually being in the room and doing some surgery. So you're looking here at a right eye. You're going to start with a lateral canthotomy and canthalysis. So you're going to, usually with diathermy, because it can give you good hemostasis while you're doing this, you're going to cut down into the lateral canthus, just to the lateral side of the canthus, find your tendon and cut it away, and you're going to release that lid. Now, that's what B is showing you. So in picture B, that lower lid is now released, and you can tell that there's an ectropion because that lower lid is not sitting nicely at the lower limbus. It's actually sitting further away, and we've got far too much scleral show. So you're going to release the eyelid, and then in picture C, what we've essentially done here is once we've released the eyelid, we're going to separate the lid, the skin and the orbicularis from the tendon and the tarsal plate. So you insert some blunt scissors, for example, and you just do some blunt dissection of your anterior lamella versus your posterior lamella. So I'm hoping you can see my mouse, but what you can see here in the light gray, just coming off the lateral, the lower lid on the lateral side, that's your tendon. And what we've done is we've removed the excess skin and orbicularis that we no longer want. So when we first released the lower lid, we then pull the lower lid to the lateral canthus and we see where we want it. And we pull it until that lower lid meets the limbus, and we see therefore how much skin we need to remove, and that gives us a rough idea. It might be about 3 or 4 millimeters, for example, and that gives us a rough idea of how much we remove. So we get rid of the anterior lamella. Let's say we want to get rid of 5 millimeters. We get rid of 5 millimeters, and then we put in some 5/0 vicryl sutures into that tendon that we've got left behind. And then using the double-ended 5/0, we suture that tendon down into the periosteum of that lateral orbit, and we pull that eyelid back up. Once we do that, you're left with a little hole, and then that's in picture D, and then you essentially just very easily just sew that back up. Nothing super complicated there at all. And that's your lateral tarsal strip. Now, whether or not you've got entropion or ectropion, you're doing basically this surgery for the involutionals. And then with the entropions, you're adding a step of everting sutures because if you don't put the everting sutures in, then it's essentially not worth doing. So this is your lateral tarsal strip. When you're doing an entropion, you're also then going to do some everting sutures. So what we've got here is a cross section of the lower lid. There in the blue, you can see your tarsal plate, and then you can see the retractors coming underneath. This blue suture, the way we do it is we start inside the eye. So we take a suture and we try and go right down into the fornix. We're going past that tarsal plate. We're trying to catch those retractors and we bring that suture through anteriorly. When we come through anteriorly, we don't want to just come out anteriorly at the same level. We pull the skin down and we actually come out only a few millimeters under the lash line. And what that does is it's pulling everything upwards because if we just came out anteriorly straight away, we're not moving anything along the vertical plane. So we're going to enter the fornix, come under the tarsal plate, catch those retractors, and then before you actually come out of skin, you're going to just with some forceps pull that skin down over the end of the needle and come out with your needle further up on the front of your eyelid, and that will pull everything up. So with a double-ended, you're going to do that through the inside, and then with the other end, you're going to again come through the inside, only 1 or 2 millimeters to the side, and come out as well 1 or 2 millimeters next to where you came out the first time, and then just tie that up. You don't tie it super tightly, you tie it slightly loose, and that gives some space for some swelling. And then you put 2 or 3 of those in, and then that will evert your sutures in. And those sutures, you're usually leaving those in a bit longer. So after an LTS, after ptosis repair, or whatever it is that you're doing, you're usually removing your sutures out about 7 to 14 days after surgery. Um, the main reason you're doing that is you want the sutures to do two things. So you want them to be there long enough for things to start to heal, but you don't want them to be there so long that when your vicryl starts to absorb, it causes inflammation. And that inflammation can then ruin mechanically what you've tried to do. So you leave it 7 to 14 days for things to start healing, but then you take those sutures out so that they're not causing any inflammation. Whereas these everting sutures will be left in a bit longer, so sometimes up to about a month, because you really want them, you actually want the inflammation to happen, because you want those lower lid retractors to start fusing properly and start pulling your eyelid away from the globe. Um, so these everting sutures will stay in a bit longer than your LTS sutures. So when you're seeing these patients maybe 2 weeks later, you'll take those LTS sutures out, but you'll leave these everting sutures in for a bit longer. So moving on to ptosis. Essentially, your ptosis is either acquired or congenital. I'm going to talk mainly about the acquired. So when looking at congenital ptosis, you've either got an isolated congenital ptosis that's got nothing to do with anything else other than a child who's been born with um, uh, poorly formed retractors. So they're left with a ptosis. It can be associated with blepharophimosis, which is autosomal dominant. These patients are going to have telecanthus. That is usually bilateral. They have a poor levator function, or it's a kind of synkinesis. So with Marcus Gunn, your um, it's all associated with your chewing muscles. So then they get this ptosis whenever they're eating, for example. And these are patients that you're going to treat with levator resection or with maybe a frontalis suspension, because actually usually their levator function is quite poor. And we'll talk about brow suspensions in a bit. So your acquired ptosis. This sort of system of understanding what acquired ptosis, the cause of acquired ptosis, is really important to try and keep in your mind. Um, so your most common is going to be involutional. You've then got your neurogenic, your myasthenic, your myopathic, mechanical, and then pseudoptosis. Remember that categorization because for your exams, it's helpful. When looking at your patients, it's helpful in coming up with differentials. So it's quite important that you try and have these sort of umbrella terms in your head so you know what to look for when you've got a patient in front of you with an upper lid that's lower than normal. So involutional is going to be your most common. It's essentially your levator's disinserted, and it's typically age related, but it can be more commonly seen in patients who've had ophthalmic surgery, especially with someone who's been a bit eager with their speculum, patients who've had trauma, chronic contact lens use. These are patients who are slightly at a higher risk of involutional ptosis. What you're going to see is there'll be a ptosis. Sometimes it's actually bilateral because, again, it's involutional age related, but one side might be affected more than the other. You'll have a high lid crease. Remember, your skin crease is made by your retractors up against skin. So if your retractors have started to recess and disinsert, then your lid crease is also going to disappear or come up higher as well. They may have an element of brow lift, and that's because they're trying to compensate. And importantly, they'll actually have normal levator function. And that's useful to know because then again, you know what you're doing with your surgery, and you can usually just do an anterior levator advancement to solve it. If they don't have good levator function, then you're needing to involve the brow in solving these patients. Neurogenic is just usually to do with your nerve supply. So a third nerve palsy is typically a complete ptosis. And you don't want to intervene immediately because you want to give it 6 months. You might then find some, disinnervations, for example, and you want to see how the patient resolves. With ischemic third nerve palsies, there are patients who do resolve by themselves. So you want to wait. And these are patients that typically need brow suspension because they essentially have no levator function at all. The thing to bear in mind is, for example, I saw a patient recently with a complete ptosis secondary to a third nerve, is these are also patients that can have misalignment to their eyes. So these are patients who, if you lifted the eyelid, they may have quite bad diplopia. Um, if they do, and they're still very keen on intervention, that diplopia needs to be solved first because when you actually do the strabismus surgery, you can alter the positioning of the lid. So these are patients for whom their diplopia needs to be resolved. You also want to try and tell these patients, tape your eyelid open for several hours in the day, see whether or not you actually want this eyelid to be opened. And sometimes these patients really don't. Um, so you want to make sure that you're doing all of that before you're actually then doing the operation, because lifting a lid, especially with a brow suspension, is a much more involved operation. Its success is sort of less reliable than just an anterior levator advancement. And the potential complications can be a bit more involved. So you want to make sure that you want to be doing this operation before you go ahead with it. Horner syndrome typically is a partial ptosis, and these again, you can either do a levator resection or just a millerectomy, depending on how much you're trying to get back. Remember, a millerectomy is only going to give you about 2 millimeters of repair. So if you've got more than 1 or 2 millimeters of ptosis, you're going to need to do something a bit more than a millerectomy. So your other causes, myasthenia, this is very variable. Now, one of the oculoplastic surgeons I worked with recently said myasthenia is always taught as something that is fatigable, which isn't necessarily the best way to look at it, because actually involutional ptosis also shows some worsening with fatigue and during the day. What's more important is actually it improves with rest. So when they have a nap, for example, or if they rest for a few minutes with their eyes closed, it improves. And that is a better sort of marker that actually what you're looking at is myasthenic. An ice pack test in clinic can be helped, and these are obviously patients that are going to be treated medically. You're really going to try and avoid surgery for these sort of patients. The myopathic things like myotonic dystrophy, CPEO, these are usually bilateral, it's symmetrical, they tend to be progressive. And again, your surgical repair really needs to be cautious with these patients because they don't have much function at all. And what can sometimes happen is because they're myopathic, they don't have very good closure. So when you're going to open their lids, they can't then close them. Remember, with most of the patients with involutional ptosis, their problem is that the eyelid is lower down, but their orbicularis is working quite nicely, so they can close their lids. Whereas with myopathics, they don't have very good lid closure either. So if you open their eye too much, they're then left with exposure and they're much more unhappy than they were before they saw you. And then the mechanical, again, it's mass effects, very similar to what we spoke about when we talked about ectropions. Pseudotosis is important to bear in mind. Now, pseudotosis is basically looking at everything that isn't the lid. So, is it the brow that's actually lower down than it needs to be? So, in those pictures up above, you can see that that eyebrow is sitting underneath that superior orbital rim, and that's not where your eyebrow is supposed to sit. And when you put the eyebrows where they're supposed to go, the eyelids then sit nicely. So then you know what you're actually doing is a brow lift. You're not actually needing to do anything with the eyelids. Then you've got something like dermatochalasis in that lower picture where you've actually got excess skin coming over that eyelid, where again, the eyelid is in the right position and all you need to do is remove that excess skin. When you're removing excess skin above the lid, what you want to bear in mind is a couple of things. So An oculoplastic surgeon will usually make their lower incision at the skin crease, and then they'll remove however many millimeters of skin above the skin crease that they need to remove. And that leaves the skin crease where it is, and it also maintains your function. The other thing that you want to bear in mind is how much skin do you leave behind? And most people will tell you that it's between 20 to 22 millimeters in terms of just the lower margin of your brow to the lash line. You want about 20 to 22 millimeters of skin remaining, so you want to be careful about removing too much. The other thing that you want to bear in mind when you're measuring that is checking that the patient in front of you hasn't actually removed too much hair from their lower brow, or whether or not they've got any tattoos or anything like that, because then you may be erroneously overestimating how much skin you're going to be left behind. The last thing you want to bear in mind is actually pseudoptosis in the sense that actually it's the other eyelid that's too high up rather than the eyelid that you're looking at. And actually, do you have a case of lid retraction rather than true ptosis? And that's something to bear in mind. So anterior levator advancement, this is typically what you're going to do for a ptosis. So what you can see here on the left-hand side is a cross-section again of the lid. What's happened is you've got your tarsus there in the sort of brown, and you've got your Muller's and your levator aponeurosis. So that aponeurosis in the white, what will slowly happen is, as you can see, there's many aponeuroses. So you've got these white lines that come across to the skin and down to the tarsus, and these can slowly start to disinsert, and that will mean that your lid goes further and further down. And each of these aponeurosis to the skin causes a crease in the skin. So if you think about that lower one being released, then that skin crease is going to go further and further up, which is why you get this picture of a ptosis with a raised skin crease in involutional ptosis. So what you want to try and do is you're trying to essentially bring forward your levator aponeurosis back down to the tarsus and the orbic. So you're going to come in anteriorly, again, usually through the skin crease or where you want the skin crease to go. Usually you can see remnants of the old skin crease. You'll cut in there, open up the skin in the orbic, and then you'll find your aponeurosis, and you'll essentially, with just some sutures, tie that down to the tarsus. It's not particularly complicated. You're going to put in a few sutures, and then what you're going to do before you close everything up is these patients are usually done under local. So you'll put some local anesthetic into the lid with a bit of adrenaline, try and control your bleeding. But these are patients who are going to be awake. You then just ask them to open their eyes and you can see where their lid is. And as long as their lid then looks symmetrical to the other side, and once you're happy with the positioning, you can then sew everything back up. So you'll put in those initial sutures that brings the aponeurosis down to the tarsus, and you'll check whether or not you've either moved the eyelid too far up or it's not enough. You'll put a couple more sutures in, or you've left it exactly where you want it. Sometimes you'll actually sit these patients up because you want to see the effect with gravity. It depends on the patient in front of you. And then if everything looks nice and symmetrical, you'll then do it. It's sometimes quite difficult to operate on patients unilaterally. So if they have an element of ptosis in both eyes, sometimes it's easier to actually just do both at the same time. So these pictures A through F show we've made an initial incision, we've come through, we've taken off skin and orbic, and then if you look at B and C, we're again trying to find out aponeurosis. D is where we're actually closing everything up. E is we've made some sutures, so we've brought that tarsus upwards, and we've asked the patient to open their eyes in picture F to see where that lid has landed, and we like where that is, and so then we'll close the skin up. A final few comments on some lid retraction. So lid retraction, many causes, can be congenital, again, isolated or to do with Downs or Duane's, remember, uh, with the third nerve and this with dysgenesis of the sixth nerve nucleus. So your third nerve starts doing absolutely everything. Typically, it's usually acquired. So either it's going to be due to a systemic problem, usually thyroid eye disease, or it's going to be neurological. So again, Bell's, or they've got misdirection of their third nerve after a third nerve palsy. It can again be cicatricial. Surgical, do they have a problem with their globe? For example, do they have a big globe? Do they have ophthalmos? And that's actually causing lid retraction. Now, the way you treat lid retraction, it's, as I'm sure you probably worked out, it's going to depend on the cause. So with something like thyroid eye disease, you're going to want to control the thyroid, and you're going to wait and see as to where that lid ends up. Sometimes what you can do with these patients is put some weights in the upper lid. So usually a gold or a platinum weight, and that will essentially pull their eye down, causing, almost like a mechanical ptosis. Um, but we want to cause that essentially with these patients with lid retraction. It's the same thing with patients with sort of lagophthalmos. So patients who, when they're trying to close their eyes, they're left with 2 or 3 millimeters of lagophthalmos. Again, a weight can sometimes help with getting that final bit of closure and protecting their ocular surface. So in summary, you're most commonly going to come across entropions, ectropions, and ptosis. And again, those are usually going to be involutional. But what's important with ocular plastics, especially with the lids, is really understanding the mechanics of what's going on in front of you. Because the mechanics are going to impact what you can see. So sometimes patients are referred to you as ptosis when actually it's blepharospasm, because even though the upper lid is further down compared to the other eye, let's say you come in with a left ptosis and their left eyelid upper lid is lower than their right. With blepharospasm, the left lower lid is also going to be higher than the right lower lid because actually you've got the entire orbit that's contracting. So it's important that you're looking at the entire eye before you then jump down and say, listen, this patient actually has an involutional ptosis, because that patient with blepharospasm won't be very happy if you then list them and perform a ptosis repair when actually they come back and they still have spasm and they still have a ptosis and they're still uncomfortable. And Botox is usually going to be what you do for those sort of patients. I'd appreciate the feedback. So please just scan that. There'll be a link attached to the video once I upload this. So please do send in your feedback. It's helpful for me to know where these sort of how these sessions are being pitched, and also just as helpful to me to, just to show that I've done it. Um, Also, there's a link in that feedback form to then send you over to be able to give me some suggestions as to stuff that you want me to go through. So please do fill out the feedback.